so much. Very good afternoon to everyone present here. We heard two fantastic talks before this. Both were lived experiences, and I was sitting there, even forgot that I was the next person to speak. So, really inspiring talks. And so, what I'm here to talk about is not something new, as I've sat through 2 days already now. This is my first time at Empower, and I'm glad that I'm here by the 5th edition of it and not later than this. And I'm thankful to Dr. Anil for introducing me to this group. I'm an audiologist and speech language pathologist by training. So the context, I just want to set a little bit on how and from where my perspectives come from. I've been working in the area of community-based hearing care, primarily trying to understand how to reach services to rural populations with respect to hearing care and communication disorders, maybe more on hearing care, especially in the state of Tamil Nadu. And over this, I've also primarily used mHealth and eHealth solutions to sort of bridge service delivery gaps in these regions. And with time, I think I've built a little bit more sensitivity from being a top-down rehabilitation professional saying, I know how to fix you, which I've heard this the last 2 days, to becoming more participatory and a stakeholder engagement-based model. And I'm learning, I'm work in progress. But I think this has been an exciting new learning to shift from a top-down approach to becoming more participatory. And by virtue of this, I'm also engaging a lot with the public sector, primarily here with the State Commissionerate for Persons with Disability. And so this is where some of my learnings come from. So as I said, I'm not really saying anything new from what I heard in terms of what is there and what are the gaps, but I think I'm bringing a little bit focus on hearing care. We've seen quite a bit on low vision and locomotor disabilities. What are the gaps that exist? I think I'm just bringing the perspective of hearing loss, bringing specific focus on certain areas of gaps, which probably is something that we can pick up and start working on. So when we look at disabling hearing loss, what can make it difficult for people with low hearing to participate in society? There are different ways to look at it. The World Health Organization says if a person cannot hear 40 decibels, which is a whisper, it's disabling enough. And if it's a child, then it's 10 decibels lower than that. But if we look at our revised Persons with Disability Act, it says 40% hearing loss, which is 60 decibels, which is basically regular conversational speech. And that too in the better ear, which means your worse ear could be worse than that. And even this, which is not being able to hear regular conversational speech, is about 0.3% as per the most recent NSSO survey. Now, if you look at this in the context of disabling hearing loss who cannot hear speech, we already see that in the Southeast Asia region, if you look, it's a significant number where we are. And if you look at hearing losses that are lower, then it's going to be much more than this. So what I'm trying to project here is that there is a large gap in terms of, large need in terms of how many require some sort of help with better listening so that they can participate more fully with their environment. Typically, how this is addressed is that how hearing loss is addressed, even through WHO, is to have a lot of screening programs to be able to early identify those having these hearing loss or hearing needs. And a lot for children happens at birth through hospitals, and in the Indian context, it's happening primarily through private hospitals, predominantly in tier 1 cities. And then there are sporadic efforts of screening in schools that take place, again limited to the urban context. And what the governments are primarily doing is for mass screening, which is in the community, like for programs with the National Program for Prevention and Control of Deafness or the Rashtriya Bal Swasthya Karyakram, is to have checklist-based screening, which are low cost, but they are not very sensitive, which means you'll land up with a lot of people who will refer and say they all may need diagnostics. And then the problem there is that we don't have mechanisms in place in terms of instrumentation and resources to diagnose, because these equipments are available in far few places. And there you see in my diagnosis, there are very few avenues. Primarily, it's available through urban clinics and tertiary care hospitals in tier 1 cities. And if you got picked up through the mass screening in the communities, then the most likely place that you would have to go to is a district general hospital, which may or may not have diagnostic testing facilities. And after all this, so even through the decade of work that I've done in the community-based services, I think repeatedly I kept tripping myself because we could provide all the screening, even diagnosis with a lot of telepractice we managed to provide. But we really then finally said, you have a problem, but I don't know what to do, because the rehabilitation aspects in terms of device availability, there was a huge gap. So typically, again, we're looking for hearing aids. Cochlear implants are available for children below 6 years at no cost. But when it comes to the rural population, even when you're providing that one-time cochlear implantation, there's a huge cost on the accessories that they require. And that itself means they would have to sell their farmland to be able to procure that accessory that got damaged. I think more recently there has been a pitch to include accessories also as a part of that package. Assistive listening devices, a lot of people who have the lower hearing losses, that is not 60 dB but below, between 40 and 60, can hugely benefit from assistive listening devices, which may not be hearing aids but simple direct audio input or an FM system. But we have a huge dearth in terms of the number of available technologies in that area. And then to be able to provide some amount of habilitation to be able to help them listen from their hearing aids. It's not really magic that if they have an implant, they just begin to start hearing. It's a little bit of work that has to be done, and there's considerable challenge with that. So the primary gaps are that when not just in terms of rehabilitation, that is having assistive devices for listening, but right from the point of being able to diagnose somebody with hearing loss, there's a huge challenge because the instruments that are required for identifying or screening are fairly expensive. Like if I have to deploy a mass screening program in Tamil Nadu, we would require 100 screeners. And yesterday Deepashri had shown images of the screeners that usually based on Western literature is bought in India, is the autoacoustic emissions and auditory brainstem responses. They're anywhere between 3.5 to 6 lakhs. And within 3 months, in fact, Kerala state has implemented a statewide program. Tamil Nadu piloted a program. Within 3 months, the probes break because it's built for air-conditioned, beautiful European environments. Then when they are using it here in India, with all the humidity, these probes were breaking in 3 months. And the replacement cost was nearly 50% of the actual cost of the device itself. And so these programs finally became unsustainable. And then the government, obviously, when they're implementing mass programs, they're looking for return on what they're doing. Finally, we're not identifying anybody with hearing loss because these programs stop in between. And when the time has come to trade off, these programs are traded off because they are not really giving any outcomes. And we really can't blame that. And then coming back to the problem, as I said, after finding, and diagnostics again is about 16 to 20 lakhs. How many places can invest in equipments like that? And we are very, very heavily dependent on these European equipments. Hearing aids, now 70% of the population is rural, and 70% of the population cannot afford what high-tech technology solutions are available. So this is the problem of the rich becoming richer and the poor becoming poorer. So whatever technology is available, I can probably safely say that if I had to have decent access to speech conversations, I would have to at least put in 25,000 rupees to buy a hearing aid. Now, that's not possible for somebody living in a rural area. So we still really don't have enough solutions. I won't say it's not available at all. There are efforts, but it's definitely not enough where people are actually able to access and buy these. And I'm just going to support that with this article that clearly says that it seems to be a little bit better for locomotor and vision, and I'm guessing that's because locomotor and visual disabilities are higher in number, and it's hearing loss is third in place. But if you see, it's only 6% of the people who need access to hearing aids actually have access in India. So, and it's the estimate is that if these people actually had access to suitable amplification devices, then the years lived with disability can reduce by 60%. And that's not a small number at all. There are free hearing aids available through the government systems, but wait time is 6 to 7 months. Now, if a child diagnosed with hearing loss is waiting for 6 to 7 months, much of the neural plasticity time is already lost. And that's very critical time. Again, if through the government systems, it's already very pressurized. So, if I need 100 hearing aids, I get only 50, 60 as disbursement. And like the example of COVID care, what happened was for 2 years, no hearing aids were dispensed at all through the government system because everything went to COVID care. So again, when priority comes, then quickly it shifts away from disability. And then, especially children are really paying the price for it because they don't have access to that critical learning period that they have to capitalize on. So what we need is what all of us have spoken about, that we need lower cost technologies that can make things more sustainable. I think I heard Dr. Namita speak yesterday that I think it will stay with me, that we don't want to become that wave that touches the feet and then goes away. We need something that, we all can create something, but if it's just going to come as a ray of hope and then vanish off, then that's a true concern. We need sustainable solutions. We need affordable hearing aids so that 70% of our population have access, not that 30 that is already getting something for sure. And we need more assistive devices like FM systems, classroom amplification systems that are lower in cost, easily implementable, that it doesn't require people to think so much, as Madhvi said. I don't need to convince people to be able to implement that in schools or colleges. So there are devices, and disclaimer, I don't support any of these, nor is it an exhaustive list, but I did see many of them in the database that was released day before. So there are lots of indigenous efforts, including the Tarang hearing aids. But the problem that I have, like everybody's pointed out, is that these are not really available. Many of them have gone through R&D, but have not seen the light of the day. Many of us who have products don't know how to reach it. And, we have now developed a screening device. Dr. Anil has supported us through the development. We have it here. And I think the concern, the anxiety is, how do we make it available? This is a funded project through Wellcome Trust. We're not really looking for commercial benefits, but we definitely worry that nobody should reinvent the wheel. What we have, we should be able to make it available. So making what already the number of people who are investing their time and energy in AT is less. And then if we don't make it more visible and quickly make it accessible to people who need it, we're losing much more time just, reinventing the same thing again and again, just because we don't know what each of us is doing. So I think the database is a great idea, but we also need to engage more with each other. And I'm actually here only to show my hand to say that I would like to engage more, and I would like to fill any of these gaps. If there's anybody in the technology side, now working with IIT Madras, I've overcome my intimidation barrier of working with engineers and IIT professors. So I think I will do better moving forward. So I'm very happy to collaborate. But I think we need to put the rehab. I come from the rehab side, so I really think we need more common language to be able to communicate with technologists, to have these products just displayed at academic institutions. I would think are very good places. We train hundreds and 200s of students. Then they go out with a mindset knowing assistive technology. And then when we have it on display, there is always going to be more, radars are up to say, okay, this patient may need this or this person may need that. So I think we need to engage more with clinics, special education training centers, academic institutions, and make things more easily available. Thank you very much for your patience listening, and I hope I've done